go ahead and take it away, and then you can just change your slides.
Awesome.
Yeah, so my name is Patrick Walker with Galen Healthcare. Galen Healthcare, we provide all transition services to organizations looking to either migrate or archive their data. We also provide application portfolio management, looking at a system holistically and understanding, okay, the more bigger digital footprint that they have, the more susceptible they are at risk, as well as reducing cost. Today, we have the VP, Chief Medical Information Officer from Valleywise Health. Welcome, Dr. Dunnigan.
Thank you. Thank you. Check, check. Oh, thank you. Wow. No. No. Oh, okay, cool. That was a tough act to follow. Wow. All right, I'm thrilled to present this actually. So hello to the folks online. This is, some of you may have seen me talk about telehealth. We've had an amazing journey over the last 18 months. I've spun that talk into an analytics talk. I did that last year, and I've freshened it up. So it's sort of 3 talks mashed up in one. So hope it goes well. Take any feedback you have on it. And we'll get caught up here too. I've got lots of cool visuals, and we'll be able to look through some of these. So let's see, space bar here. Or, let's try. There we go. All right. Who remembers looking at this last year? Yeah, I know. Who was looking at it 10 times a day and hitting refresh? So I've got my first few visuals are from August of last year. I've kept them intact. This talk's like a little slideshow or a little time capsule almost. So, you know, so one of the themes I'll touch on is, you know, we've used this horrible crisis in a couple of ways. It's been a couple of perfect storms and silver linings to get where we want to be. I'll walk you through some of our telehealth journey here. And it's been the golden age of data and analytics. So to be able to look at data like this, you know, I've got some slides with no words on it, and you can just, you know, this is what we're trying to do in healthcare, right? We're trying to come up with visualizations and dashboards that tell a story without a whole lot of, you know, interpretation or PhD level work. And so this, and then of course, you know, when we rolled out our own at the state, right? I mean, we were looking at this every day. You know, what's the percent positivity out there? What's the ICU availability? What's the ventilator availability? So we were looking at this every day, multiple times a day. I'll share our telehealth journey with you briefly. We stood that up, you know, literally overnight. And then, you know, this is back from August. So finally, my attention was drawn more to this in our system here about, you know, how are we doing with telehealth? We came up with our own dashboarding around COVID. And so, you know, it's very compelling to use this crisis to get us into a whole new era with data and analytics and visualizations. And it's all meant to tell a story very quickly. You saw I'll dive a little deeper into our telehealth adoption curve. It's incredible. I mean, to turn it on overnight, and we had thousands and thousands of visits over the first few weeks. And I love this slide. So some of you may have seen this before. This is the adoption curve of various technologies over the last century. And it's crazy how you move left to right. You know, it took decades for electricity to be widely adopted, refrigerators, things like that. Then we get to the right, things like social media, smartphones, and tablets. The curve is like that, right? So, you know, I look at our telehealth curve, and it feels more like it is to the right, and that's just the way it is. And of course, telehealth was the perfect storm, right? I mean, we had an absolute pressing need to deliver care to patients in their homes, to keep people out of the hospital, so we could utilize those resources for patients who thought they might have COVID and were sick. And I love this next visual. I'm like, you know, what does that compare to these days? And it almost feels like this, right? I don't know if people have seen this visual. This is Pokemon Go back a few years ago, 2016, and that crazy summer. You know, my teenagers, they're older teens now, but this was the height of, you know, watching them walk around with their phones and chasing Pikachu around. And then you see this steep drop off. So I look at that and laugh, because, you know, what we want to do is avoid the drop off, right, for telehealth. We want it to be out there forever. And so, again, you know, data visualizations and telling a story. I've got a couple, obligatory slides here on Valleywise. So many of you know us as Maricopa Integrated Health System, Maricopa Medical Center. We've been around a long time. Since 1883 to be exact. We've been in this building for many years. I don't know if you drive, I've got a photo of what the new building will look like. If you've driven past 24th Street in Roosevelt, you see that thing going up. There's wire all around it now. I was up on the roof the other day. It's pretty cool what we're doing on that campus. We're refurbishing all of our clinics as well. And thanks to you as taxpayers for helping fund that. Back in 2014, that was Prop 480. So just shy of $1 billion to completely reimagine our whole system. We've been the safety net system in town for a long time. We've got the main medical center. We've got the Arizona Burn Center. We have the largest burn center west of the Mississippi. Trauma, behavioral health is a significant book of our business. We've got the 12 FQHC clinics. We're going to have 10 at the end of the day, 10 refurbished or brand new facilities. And we're the largest teaching hospital in the state. Lots of learners, residents, students, and lots of visits annually. With this payer mix, right? So, we pride ourselves on being the safety net system. We're a Medicaid shop largely. We have a large number of uninsured patients. This is a couple years old. That number's unfortunately climbed over the last couple of years. But we take all comers. I think part of our rebranding from, County Health and Maricopa to Valleywise is, we're trying to differentiate ourselves and be the hospital for everybody. Here's a schematic of that new building. It's starting to look like it. My gosh, I was in on the ground floor. It's just a massive facility. It's going to be really cool. We're a couple of years away still from that opening up. You can go to carereimagine.org and there's cameras and you can kind of follow along over the next couple of years on our reimagination journey. We're an Epic shop. So I've been there 7 years. We've been on Epic about 12 years. We were doing these biannual upgrades, these large, painful upgrades. We've moved to a quarterly upgrade process now. Most of the Epic shops are doing it quarterly. It's a different skill set. It's become continuous now. So we've had to sort of shift how people work on Epic and do these upgrades. The nice thing is we're always at least 6 months from the next version and being up to date. So that's allowed us to be much more nimble in our shop. All right, so March 17th, 2020. I call it D-Day. And it's truly a day that will live in infamy. We closed our office down the day before, and literally this memo came out from the OCR, from the Office of Civil Rights. I had 4 people forward this memo to me that day. And this memo basically says, it's a whole new world. The business rules have changed overnight. You can connect with your patients pretty much however you want. FaceTime, Facebook Messenger, Skype. Somewhere in this memo it said we advise you don't use TikTok and some other things, but you have it. And then there was a short list here. This is the actual memo with some semi-sanctioned tools that have a telehealth play. So I know I had doctors reaching out going, hey, I just started FaceTiming my folks today. Are you cool with that? I'm like, what are you doing? So we knew literally we had about 24 to 48 hours to do something. So we looked around, we looked at what we had available. We had a very, sophisticated Cisco tool that just was going to be way too much for our patients, way too much for our providers. We ended up looking at Doxy.me, which had a free version. I hosted a St. Patrick's Day happy hour on it that night. And the next day we were actually piloting and off and running. We were able to get it up and running really quickly. We didn't try and integrate anything. And to this day, it still sits completely outside of Epic. We kept everything intact in Epic. The scheduling, the note template, we added one little smart phrase ultimately that said, I'm doing a telehealth encounter. I'm in the office, the patient's at home. We had a couple toggles there. That allowed us to just get this up and running immediately. We did take some care. There's all this intricate magic as an encounter flows with all the billing mechanisms. We've been able to not have to go back and redo a lot of that, even 18 months later. So that's the incorporation of the billing magic here. And then we brought in the operational folks on day one. And I think, as I tell the telehealth story, it's truly a perfect storm. We finally had alignment of the technology. We had the technology in place for a long time. It was the operational pull with a technology push, and then figuring out the business process literally overnight. having it change, and suddenly it all aligned. And we were off and running. And we made lots of tip sheets. And we still make tip sheets every day. Rapid iteration. So, we started with this, one of my super users, Cassandra, just doing it on her own phone. We had people using their own phones for this for a while. We ultimately moved to webcams, headsets, fancier stuff. We moved to the paid version of Doxy, which had some more bells and whistles. People were able to spin up their own virtual rooms and put some wallpaper on it and things like that. And this is still in place today. I'll show you some of our current numbers here shortly. So, again, data and visualizations. This is data from April of 2020. I worked with our marketing department. I wanted to make sure, because we didn't have time for an ROI, a TCO, all these things we try and do strategically to create a business case. We were flying by the seat of our pants. How are we doing? So this is a provider survey, and I love, anytime I see this as a CMIO, will you want to use this after COVID? 86%. I felt that we were on the right track. I give my DMG colleagues a lot of credit on our operational folks. They were able to do what they needed to do almost immediately. To reach out to their patients at home, keep healthy patients at home, bring the unwell patients in. We ultimately had providers who tested positive. They're able to work from home and see patients. So the satisfaction around this was huge. And the patient experience was really good too. I'm the CMIO at a safety net system. I love slaughtering the sacred cows of this is too much for our folks. It's too complicated. Our patient, we've got many, many patients who English is not their first language. Not everyone's got a phone. Not everyone's got bandwidth in their home. So by and large, some of our patients had to find a family member, or they had to go to the library, or we figured a lot of this out, and the patient satisfaction was very high, even to this day. So I'm really proud of that. We're all drowning in data, right? So switch to kind of the data spin on this. We took a 30% hit immediately. We were able to get back on track within 60 days. How do I present that to the execs in a way that makes sense? How do we look at that data in a way that lets us, make these decisions really quickly? That's where some of the visualizations come in. We embraced Tableau. We spun up a Tableau pilot. We've got some cool visualizations in Epic. Tableau allowed us to do some things we couldn't do in Epic. So this is current data as of 2 weeks ago, right? These curves. These are the curves we've lived through. April of 2020, oh, well, this is happening. Okay, the offices are shut down, but it's not too bad. Then came July, and we were at the epicenter of the whole world. I was on TV. My friend Frank Lavecchio is still on TV every night. We lived through that. Okay, we might be out of it. Come the winter, oh gosh, here's wave 2. And then we got to this place. I'm like, thank goodness the pandemic's over. And then Delta hit, right? Here we are. So we're sort of on hopefully the smoldering embers of the Delta. So much like those CDC and state websites, we started looking at this every day. So my CMO gets up in the morning and looks at this, and we make decisions based on some of this data. So I asked, can we use Tableau to come up with some of the telehealth visualizations? So here's our visit volume. I'm blocking the number here. It's 248,000 over 18 months. Went from 0 to 248,000 in 18 months. And you'll see that, you see this variation here. So it hasn't been a constant. And why is that? I've got a slide coming up on that. Our no-show rate. Look at that. The virtual visit no-show rate is half. The no-show rate is half of what it is for in-person. So we've been able to take advantage of that. So here's COVID. See, the orange is the COVID waves I showed you. There's that first peak summer of last year. Here's the winter. There's Delta. We've been able to tweak our percentage of telehealth based on where we're at in the pandemic. So it was as high as 50, 60% on some of these waves. What we'd like to do is keep it around 30%. We think somewhere between 25 and 35% is our sweet spot. So I've shown this to people and they get a lot, it just makes a lot of sense, right? And this has helped us make some of those decisions about what's our ideal ratio, how do we want to tweak that number actively. I love this one too. So this is audio only versus video. So we were really rocking the phones, and we still do. You know, again, you know, we're very cognizant of the digital divide. You know, how can we quickly engage our patients? We've really tried to push the video. The video has been pretty constant. And you see now it's over half of our business is on that video platform. We worked with the governor's office. We know the rules are going to change. There's going to be some sort of audio only guardrail, but it's largely going to be interactive audio video. That's here to stay at that reimbursement rate. So this is data we're very keenly keeping an eye on. And then, you know, again, you see the blue here, this is the virtual. With that 30 to 50% virtual, it got us back to where we were. And then combine that with the no-show rate cut in half. We actually, our clinic business exceeded where it was in 2019. So it was just incredible. And that wasn't my primary goal. My primary goal was to give something people could have so they could stop FaceTiming and Skyping. I could support them. And again, we could have people working at home. We could keep the patients at home. It just happened to save our system. And now I've got the data and analytic tools to show them that. So we're still in telehealth in a very tactical place and trying to think more strategically. So as I give the telehealth talk, I could do a deep dive on this, but you know, we've had to figure out a lot of things. You know, obviously the patients aren't coming in. So how do we get them the immunizations they need, the cancer screenings they need? Those numbers are down. And part of figuring out that ratio is to get people back in for those things. Those are obviously crucial. Picking up your meds, getting labs done. So we've had to figure a lot of that out. All these things we've been talking about for years, store and forward visits, e-consults, these interprofessional consults, you know, other types of telephone care. How can we bring more of this to the extended care team, nurses, care coordinators, folks that do pop health? All the rules changed about where you could be. Now I can be out of state, the patient can be out of state. We've even got some use cases, you know, some of our patients are in Mexico. This is some special things we've done. You know, Arizona's been a very progressive leader in this too. So I'm really proud of that. Home device integration, gosh. So now I can be on a video visit with a patient. I can watch you take your blood pressure, validate it, and that counts as real data. So in our FQHC reporting, we can count that. And we're working on some other things, weights, you know, home hemoglobin A1Cs, home Coumadin checking. So the door's wide open to a lot of that. Interpreters, gosh, that was huge. You know, we now have the interpreters on the doxy. So I can have up to 10 people on those video chats. We've used this for virtual family visitations as well. So we roll this into our infectious disease units, and we can do some of those goodbyes. And then, you know, 18 months out, starting to think much more strategically. How do we meld all this together? How do we take advantage of the virtual visits and connect those to in-person visits in a way that makes sense? Again, so we're making sure we get the immunizations done, the cancer screenings done, all the things we need to do for folks with diabetes, high blood pressure, all those other chronic diseases. You know, it's changed. It's funny, we were, you know, halfway through the Care Reimagine process, building new clinics. None of our clinics were built for telehealth. So we've had to go back and refurbish some of the clinics and have rooms. And you know, one of the lessons I learned, we thought telehealth was going to be this sort of complicated, fancy thing with middleware and tools. And it's much easier than that, right? It can be a doctor on their phone talking to a patient on their phone with the EMR as is. So we've done some modernization even in the brand new clinics. We brought in sound curtaining and things that help protect that PHI. We've had to change the way we think of our staff. You know, medical assistants have become telefacilitators. So we were able to duplicate that in-person flow almost verbatim virtually. You know, depression screening, tobacco, alcohol. You know, those screenings are really important. Those metrics count, you know, so much for UDS and all that, all the things we're on the hook for. And then all these other enabling technologies. We're in a partnership with Nuance. If you've seen that, they call it DAX, the Dragon Ambient Experience, that thing that sits in the room, looks like an Amazon Echo that'll write the note for the provider. I don't know if I've got some really cool videos on that. So they're in cahoots with Epic now. So it's really opened the door for some of these other enabling technologies. I think that's my last slide. I told you I'd get us back on track. I'm appreciative for my informatics and analytics teams. So, you know, in a nutshell, I've leveraged the telehealth experience to be able to tell a story, and data analytics has become the platform that I can tell that story to. And folks look at these Tableau dashboards daily now. And I love them because I don't have to explain it. You know, you see those waves, and I superimpose the visit volume on that, and we can, you know, shift that. So we're trying to deepen our play now in things like Tableau and other visualizations. And, you know, I'm just, anything I can do to leverage this horrible crisis, I'm doing that every day. So, so thank you guys. Take any questions on any of that or anything. I think we've got some time. So, yes, ma'am.
Where, you know, like we, you know, now they're all at home. There's sort of these like processes surrounding that now are not need to be virtual, right? So like registration, things we do to get them prepared for it. How did you sort of manage that? Was there
Yeah, it's a great question. I think folks thought we could turn some of this on and we wouldn't need all the staff that are doing all the warm communication and the hand holding. And it turns out they were even more important. You know, we've saved no money on staff. They're doing the same work. They're just doing it in a different way. We reach out to the folks to make sure they've got some device. Doxy is nice because it runs on anything with a browser and a camera. If you've got those two things on a device, Doxy will work. Not everyone's got our bandwidth at home, right? So sometimes it's choppy, and then that's why we've had to revert to the phone, and that's why we worked with the governor's office to make sure we've got some sort of audio only. To your point, we've had to become really good at that telefacilitation, and we're still learning. So yeah, it takes a lot of warm human contact to make all this work. It's definitely not plug and play. So it's a good question. Yes, sir.
It was interesting you were pulling the charts and showing with your answering the question, how many people will continue to place the design?
Yeah.
How did you measure that?
So we conducted surveys. So we did a survey monkey for providers. Then our marketing folks had a fancier thing we were sending to our patients. I was just really interested in that early feedback, and we leveraged that. And we still do. So we're rolling out a new one now as we've gone, you know, so we've iterated this tool. It's a little fancier now. You know, everybody's up to speed on this. We're doing more video over the audio now. So I'm very interested to make sure we're still moving in the right direction. I'm just, you know, so the governor has a task force. I know Dr. Goldberg, who works closely with me, is on that task force. Again, you know, our folks that have a digital divide, we're going to have some sort of audio guardrail, but we got to get more people comfortable with the video technology. I think surveys like this help, right? What are your barriers at home? Is it bandwidth? Is it your device? Is it just, we did a COVID thing in our parking lot, and the front door was a very simple scheduling web app thing we did. And I swear to God, I was in the parking lot helping folks on their phone. They would drive in and I would get them in and get them booked. And some of these folks had never, I swear they'd never used their phone before. Like they didn't know how to send a text message. They were trying to call their daughter. I'm like, so those are our patients. And we need to cater those folks. So we've still got some work to do on that front. Yeah. I'm very cognizant of that, especially as the rules change, right? So.
Social determinants of health. Everybody's heard that phrase over and over again. It feels like it would be very tempting in a video setting to try and peek a little bit, see what's going on, or maybe just ask, hey, take me around your house.
Yeah.
How did that play out?
Yeah, we absolutely do that. People love it. We're looking at people's fridges. We ask our patients not to do it while they drive. They still do. But that's fascinating, right? Yeah, families, support system. I mean, I think of, you know, diabetes education, nutrition consults, you know, therapy consults. It's been a huge benefit to be able to peek in our folks' lives, literally, talk to other family members, and yeah, they'll walk around the house with the patient's permission. You know, we get a verbal consent to conduct these visits virtually, and that's part of it. It's because we're literally coming into their home. We make sure they're in a place where they can, you talk privately and their information is protected in their own home. So.
And then how do you capture that? Free text?
Yeah, typically you're conducting this and then you're sort of got the EMR beside you. We're trying to look ahead and see what's the integrated model like that. Epic's now kind of spun up they bought Twilio and they've come up with a de facto version of doing more of this integrated. I think we've had some discussions. Is there a day where we record the whole encounter and break it down? We're not doing that today, but that's an interesting thought, right? I mean, how much of that do you capture? So. But yeah, right now the doc, we're conducting. It's like you're in the room with me. I'm over here typing or talking or dictating, and it's just a different modality for us having that conversation. So. All right, I think we're caught up. Okay, you bet. Cut back to follow. Oh, Brian. Thank you.